So we're going to talk about advanced endoscopic management techniques for pancreatic malignancy. And first, we'll take a look at palliation of duodenal obstruction. So we just heard from Priya about obstruction in the bile duct and what happens when the duodenum around the pancreas head gets obstructed. And then we'll look at some of the therapies for pancreas cancer that are delivered endoscopically: celiac neurolysis, fiducial placement, and direct treatment of tumors with injection of anti-tumor agents, ablation of pancreas cysts with alcohol, and ablation of pancreas tumors. So about 15 to 20% of patients will experience duodenal obstruction, and the options for drainage are largely endoscopic with a stent versus a surgical drainage. So here's a nice diagram. You can see the sweep of the duodenum here coming around the pancreas head, and often a tumor in the head of the pancreas will obstruct this area, causing delayed drainage of the stomach. So here's a diagram of the same type of stent that you just saw from Priya. So this is an enteral stent. It goes into the lumen of the intestine and then opens it up. These are soft mesh tubes you see here. Here's a view of the endoscopic view at the pylorus, and you see the obstructed lumen, and we find our way with a wire and then expand the stent to open the lumen. So when we look at the outcomes of stenting versus surgery, the clinical success is similar, about 70% success rate. The immediate complications are less for the endoscopic approach, and then the cost for the endoscopic approach is somewhat lower. And here's a study that compared duodenal enteral stenting versus a surgical gastrojejunostomy. And they found that there was slightly quicker food intake with the endoscopic approach. The problem that we tend to have with the enteral stents is that they do induce a tissue hyperplasia. So it's not typical that the tumor itself will grow through the stent, but there's a thickening of hyperplastic tissue response that narrows the lumen over time. And this can require repeat intervention. So the long-term patency is better with surgery, but the short-term complications are less with the endoscopic approach. So typically we will begin with the endoscopic approach and then reserve surgery for failures. So we've heard about endoscopic ultrasound to evaluate the pancreas. This is a nice diagram of how the scope is moved through the stomach into the duodenal bulb and then the second duodenum, and we can see through the wall of the intestine to visualize the whole pancreas. So here's the head, the body, and the tail. So by moving the scope, we get nice views of the entire pancreas. And we've had an interesting tool available over the past 5 years where we can look through the wall, and then this sort of double bumper stent called the Lumen Apposing metal stent can sort of anchor adjacent structures to the stomach or duodenum. And these have been termed LAMs, or Lumen Apposing metal stents. And Dr. Itoi from Japan first described this procedure in 2014, where perhaps instead of working through the obstructed duodenal lumen, could we kind of duplicate what the surgeons do and try to go through the wall of the stomach and make a gastrojejunostomy endoscopically. So this technique is still evolving and being perfected, but here's a nice diagram where we can see through the stomach wall, and instead of working through the obstructed lumen, if we can make an anastomosis between the stomach and the jejunum, and then you see that stent over here with this double bumper configuration. So some early data compared the EUS-guided gastrojejunostomy versus a laparoscopic gastrojejunostomy. The clinical success was fairly similar, 90% for the surgical, 84% for the EUS, but 1/3 of the endoscopic cases needed sort of a salvage with a second stent. So 1/3 of cases would not succeed just utilizing this single stent. The length of stay was similar, about 9 days for both patient groups. there were complications of bleeding and peritonitis with the endoscopic ultrasound approach. And here's a somewhat uncommon complication, but after Whipple procedure to the surgical resection of the pancreas head, sometimes the afferent limb can be obstructed by recurrent tumor. And this was a case we encountered. So we see a markedly dilated afferent limb. You can see fluid in a very dilated small bowel segment. And this is where the bile ducts drain into this area. So the patient presents with jaundice because the bile cannot be drained. And we were able to use one of these Lumen opposing metal stents. So here we see the very dilated small bowel with fluid from the stomach, and that's our target for drainage. So we enter the dilated afferent limb with a Lumen opposing metal stent. Here's that distal flange that opens up like an umbrella, and then we pull the small bowel up against the stomach. And then the gastric side of the double bumper is open, and you can see all this fluid moving where that fluid under pressure is now draining into the stomach. So here's the endoscopic view. We get a marked rush of this bilious fluid now able to drain into the stomach, and this is how it looks from the gastric side. So how about a direct therapeutic role for endoscopic ultrasound in pancreas cancer? So EUS is, here's a needle coming out of the EUS scope. So in real time, we can visualize a pancreas tumor and then adjust the needle to sample the tumor. We can achieve about 90 to 95% diagnostic accuracy for the cytologic diagnosis of malignancy. But how about actual therapy? So this question has been ongoing for approaching 20 years now. And the most well-established therapy is EUS-guided celiac plexus neurolysis. We can see the celiac ganglion or the region of the ganglion very well from the proximal stomach. So here's a nice diagram, the EUS scope in the upper stomach. And we can see the celiac artery and know that the nerves of the celiac ganglion are surrounding that area. We can bathe that with a solution of alcohol and bupivacaine, and this can be quite effective in reducing pancreas cancer pain in up to 3/4 of patients for up to 6 months. It can be repeated if needed. Recently, people have recognized that we can actually, in about 1/3 of cases, see the actual celiac ganglion, and instead of bathing the area, we can actually directly inject into there and perhaps improve the response to therapy. We can, and we'll hear more about this from Dr. Yohung, but we can assist the therapeutic radiologist in identifying the pancreas tumor by placing fiducials into the pancreas tumor. So initially, we used to have to do this ourselves with backloading gold fiducials into a needle and then covering with bone wax. And now we have preloaded specialized needles that can assist with this. And the first reports of fine needle injection of a potential anti-tumor agent go back to the year 2000. And there's been several trials utilizing cytoimplants, agent tianephride that is a radiosensitizing agent, and injecting chemotherapeutic agents directly into the pancreas, such as gemcitabine, that could potentially be used in conjunction to systemic chemotherapy. So this is a fairly easy thing for an endosonographer to do, but unfortunately the agents so far have not demonstrated great success in improvement in survival. And how about actually directly destroying a pancreas cyst or pancreas cancer? So there's been a number of trials looking at EUS-guided chemoablation of mucinous pancreas cysts. So we heard from James earlier about these cysts, and we can sample the fluid. Here's a cyst here. We see a nodule on the wall. Here's the needle going into the cyst. So we can analyze this fluid or sample the cells, in the cyst wall or nodule. But just like the radiologists do for liver cysts, perhaps we could drain the fluid and then inject something into the cyst that would destroy the precancerous lining of the cyst wall. So typically this has been done with first alcohol and then a combination of alcohol and paclitaxel or other chemotherapeutic agent. In a systemic review, the complete resolution of the cyst lining has been achieved in about 53% of cases, with a partial resolution in about 1/4 of cases. So the ability to reliably destroy the cyst lining has been okay, but really not as good as it ideally would be. It's been quite safe overall, with about 7% of complications of typically self-limited abdominal pain and typically mild pancreatitis, and only about 4%. So how about using the same technique of ethanol ablation to destroy symptomatic insulinomas in patients who are not surgical candidates? So this was a series from the Mayo Clinic where 6 patients presenting with severe hypoglycemia who were not surgical candidates. And the mean tumor size of the insulinoma was about 16 millimeters. And very small amounts of alcohol could be injected, typically 0.75 milliliters, and a mean of 2 EUS-guided treatments. And all patients had symptomatic improvement with marked improvement in the hypoglycemia, and the complications were minimal. 1 patient with abdominal pain and a self-limited pancreas fluid collection. So lastly, how about treatment of adenocarcinoma? We have on the horizon better needles available for direct treatment with either radiofrequency ablation or cryoablation, tools that the interventional radiologists have had very good success with. This is a review of 42 cases. Most of the data on this is so far very small little case reports or case series, and when compiled, they had 28 cases of adenocarcinoma, 7 endocrine tumor, and 7 cysts. Of those 42, they achieved technical success in 36. There were 6 cases where they had trouble entering the tumor because of the desmoplastic response of the tumor, and it was hard for the 14-gauge needle to enter the center of the tumor. The complications have been relatively minor, and 20% self-limited abdominal pain and bleeding. So in this area, I think for several decades now, endosonographers have been sort of excited to have a potentially more therapeutic role, but multiple questions persist. So which patients could potentially benefit from a local therapy for a disease that's often considered a systemic disease? And could we possibly assist in the downstaging of locally advanced tumors with a localized therapy? There's a lot of work to be done for technique optimization and for each individual therapeutic approach, such as alcohol injection. Brachytherapy seeds have been delivered by an EUS needle, and the parameters of RFA and cryotherapy. The safety profile has been quite good overall. We're always concerned about the potential for severe pancreatitis from manipulating the pancreas and the potential for vascular injury, and ultimately whether or not these local therapies can deliver a survival benefit. Thank you.